all of you. It is my pleasure to meet with you this morning remotely. I've never had the pleasure of being in Haiti. One day I hope and promise to be in Haiti to work with you all. My goal today is to talk about lower urinary tract dysfunction. I apologize if you hear some noises. I'm in the operating room in the back, so periodically you'll hear some extra noises. So my plan today is to talk to you about lower urinary tract dysfunction, voiding dysfunction, how it could be diagnosed based on symptoms alone, and with very little screening using the guidelines. So the focus is primarily on symptoms, and that's what I'm going to talk about. In general, LUTS or lower urinary tract dysfunction, assuming that you have ruled out reversible causes, such as the intravesical pathology or reversible causes such as urinary tract infection, and often they are caused by bladder being overactive, there's an outflow obstruction, or the urethra is incompetent. There is the category of dysfunctional voiding, which is less recognized, and overactive bladder with pain, which is interstitial cystitis. These are buckets of diagnosis, not necessarily each a separate one. There can be an overlap. When you're looking at a patient who is presenting to you with lower urinary tract symptoms, your assessment should answer, what is the possible etiology? What is the severity of these symptoms? How it affects the quality of this person's life? And what are you intending to do to improve those symptoms? Most common symptoms of lower urinary tract dysfunction are frequency, urgency, urinary incontinence, pain on urination, getting up at night, and hematuria. Of all these symptoms, nocturia, getting up at night, is the most bothersome symptom. It disturbs the quality of life more than anything else. Second to that is urgency. Fear of leaking is just as bad as leaking. The urgency causes certain behavioral changes in the pelvic floor, which we see very often. So if you take the symptoms of frequency, you should be able to ask 3 questions and get an answer regarding the etiology most of the time. So the questions are, is the frequency at daytime, or nighttime, or around the clock? Is it high volume or low volume, with or without burning, discomfort, or pain of some kind? So if you take the frequency, and if it is day versus night, it makes a difference versus the round clock, as well as the duration. So let's take an example. The first example is, as you can see, it is around the clock, it's small volume, it's 3 days in duration, it's associated with pain, urgency, and incontinence. The diagnosis will likely be UTI because this is recent onset, it is small volume, it is day and night, is it associated with burning, and of short duration. Now, if you take that combination as detrusor overactivity, again, it is a motor activity of the bladder. It is around the clock, mostly small volume. It can be present for months or years. It is associated with urgency and incontinence, but rarely no pain associated with this. If you take diabetes mellitus related frequency of urination, this is again round the clock, but it's large volume, presence for months to year. It may or may not have urgency or incontinence. It's just volume induced frequency. Person with congestive heart failure or peripheral edema will have nighttime frequency, which is large volume, present for months or years. It may have urgency plus minus incontinence. So focal affection, that means a person having pelvic floor dysfunction or sensation-related urgency or frequency will have daytime symptoms only, small volume, present for months or years, and again, associated with some pain due to pelvic floor guarding and urgency. So if a patient comes to you, what I ask is a discriminator question. The discriminator question is, how many hours are you able to sleep at night without going to the bathroom? If the person tells me they can sleep 4 to 5 hours at night, they don't have a bladder pathology. It's unlikely that they have bladder pathology only during the day and not at night. So that requires some other diagnosis. And typically that is sensation-driven frequency. If it's small volume, it's high volume, then it's related to large intake, which causes the frequency during the day. Whereas if the frequency is only at night, it is related to peripheral pooling, which is accumulated fluid in the legs. Because the legs go up, they put on more urine output at night. Similarly, with the urgency, you have to ask the question, is it associated with frequency? So a child who postpones the desire to urinate because they're very busy with playing and has urgency to go when they have to go, but they only go 3 or 4 times at night, that is related to postponement. And just putting that person on a time voiding schedule, you would avoid the urgency. If it's associated with incontinence, the urgency is most likely due to detrusor overactivity. Again, is it present only in the day without leaking? It's related to sensation. A person sleeps throughout the night and has frequency and urgency during the day. This is most likely due to a sensation coming from the pelvic floor causing the frequency and urgency. Many patients complain of change of position related urgency. This typically happens in women who have some degree of pelvic prolapse and or open bladder neck. As they change the position due to Valsalva, the fluid enters the proximal urethra, gives them a sensation of urgency. There are situational urgencies, which is as I enter the house, I need to go. If I'm in the cold area, I need to go. You must ask the question related to the urgency to know the severity by asking, can you postpone the urination for minutes, longer, or forever? The person related to nocturia, it is the number of times you get up. There is no strict definition in terms of number of times that you have to urinate. The person's longest interval between voids is what we need. Small volume versus large volume. If you have somebody urinating in small volumes throughout the night, they most likely have sleep disturbance or something else, such as restless leg syndrome is waking them up, or sleep apnea that's causing them to go more often. If they have associated daytime frequency versus selective nocturia is what you need to define. Volume voided at night determines the type of treatment you're going to give. The most conservative is to reduce intake 2 hours before going to sleep, and leg elevation during the evening hours reduces the urine output at night. Also helpful is to change their diuretic. If they are taking a diuretic, instead of taking in the morning, they should take it late afternoon to reduce the urine output at night. So 3 to 4 in the afternoon is the ideal time to take a diuretic in these patients. The incontinence needs to be defined. Is it associated with urgency? Is it associated with stress maneuvers such as Valsalva? A continuous leaking after dribble? This is after I finish urinating, I get up and I dribble urine, or with change of position. I get up and I start to void. Giggle incontinence is described in pubertal females more commonly. This is a form of a combination of detrusor overactivity versus incontinent bladder neck. you need to define by history if the incontinence is associated with urgency, is it related to an effort, or is it mixed? Most common is mixed incontinence. Once again, by defining the urgency and frequency is only in the day and the person can sleep throughout the night, that lady most likely has stress incontinence, but she's going frequently in the day to avoid leaking. If the bladder capacity is good at night, she has almost pure stress incontinence, and she has defensive frequency during the day. Continuous leaking is often related to a fistula, that is with a history of hysterectomy or obstetrical injury. Otherwise, fistula is unlikely. Rarely in children, it's due to an ectopic insertion of a ureter. So depending on the age and history, you need to look for a fistula. Insensate leaking. Insensate leaking is persons wet, but they don't know when they are leaking. This is most commonly in women who are heavier, their thighs come together, or they're in a hurry to urinate. Some urine is going into the vagina and is leaking out subsequently, causing their pads or clothing to be wet, typically a small amount. A specific post-void dribbling is as I get up after urination. Now, post-void dribble is more common in men. This happens due to pooling of the urine just above the membranous urethra, and this is from straining or pushing at the end of urination. When you bear down, your pelvic floor will tighten. I'll talk about this a little bit more when I talk about male symptoms. One needs to assess what is the amount of leaking. Simply knowing how many pads they wear may not be enough, because pad count can be dependent on how the person likes to change their pads. Sometimes they change their pad with a very little urine loss. Others like to wait till they are completely soaked. So you must ask the question, is the pad just damp, wet, or soaked? Leaking, again, requires to know how bothered they are to be able to treat the leaking. Associated lower urinary tract symptoms are helpful in the diagnosis, such as with urgency, the frequency would be helpful. And if it's painful urination, which is of recent onset, that would most likely be a urinary tract infection. Pain can be associated with voiding while urinating. That is called dysuria. That is, again, most commonly associated with urinary tract infection. Is the pain relieved with voiding? A suprapubic pain relieved with voiding is typical of interstitial cystitis, because the stretch of the bladder causes pain. Pelvic pain is most commonly due to excessive guarding of the pelvic floor as a defense against leaking and or prolapse. It's a stress response for many patients, so their pelvic floor is too tight and they are unable to relax during voiding, which causes not only urinary discomfort, they also have sexual pain and bowel disturbance. 70% association with irritable bowel syndrome. Urethral pain most commonly is due to a urethral diverticulum, sometimes due to other rare pathologies such as stone and or malignancy. Vaginal pain is seen in postmenopausal women with hormonal loss and thinning of the vaginal wall. Physical assessment in a woman should consist of assessing the descent, not only looking at the urethra and the bladder, but the entire pelvic floor. Their ability to contract the pelvic floor is best assessed by doing a rectal exam, which also allows you to do a regional neurological exam. If the rectal tone is lost and they're having a urinary incontinence, that person has a lower motor neuron lesion that causes urinary leaking. Pelvic muscle or levator tenderness is an exam that you need to learn while doing a vaginal exam. This is present in patients who have excessive guarding typical point of tenderness is where the ischial spine is and or near the pubic tubercle in the muscle. By doing these pinpoint painful situation, sometimes you're able to do a trigger point injection of a local anesthetic there to relieve this pain. Stripping the urethra to assess for diverticulum is important. Also looking at hypermobility of the urethra when they bear down or cough to see if there's a motion related to urethral support. That's a pelvic exam in a woman. It takes about a minute, and you can get a lot of information from knowing their pelvic support. It is helpful to have the patient keep a diary for 2 days. There are many apps available now, such as a BladderPal, but a paper diary is good enough that they can keep how often they are urinating, if they can measure how much they're going at a time, their fluid intake, and some leaking episode. It helps to have the number of pads measured in terms of the amount of urinary loss. A diary looks something like this. So as you can see on this, that there is 24 hours of the day are listed. They either mark urination or they have an accident. If they're able to measure the volume, and in this example, you can see this lady is urinating 200 to 400 cc's every hour, and this relates to a large volume output. And of course, it is associated with large intake, which is the bottom half. So large intake, large void, this person has diabetes and her sugar control is poor, and this is volume-induced frequency. Simply by the diary, you can make this diagnosis. When you have stress incontinence, you should be able to quantify the degree of leaking, how many pads, bother, if there is associated anatomic descent or just urethral hypermobility, if there is associated dysfunctional voiding and or frequency. If you correct the anatomical descent, the frequency may not improve, and that's what you have to caution with the patient. If I'm doing a sling and the patient expects to get up less at night, that's not going to happen. And my procedure will be unsuccessful because her expectations were that she would get up less at night. It is important to know what is the patient bothered by that you're trying to fix. Similarly, with the overactive bladder, the diagnosis of OAB is made very common, but you have to define, is the OAB with incontinence or without incontinence? What is their functional volume? How much are they able to hold, particularly at night? Because that becomes the goal in bladder training program, that I should be able to achieve that capacity during the day. If you're doing a urodynamic study, I need to know at what volume is the bladder contracting so that I can plan, is this patient a suitable candidate for bladder training if the contraction occurs at 300 cc's, whereas the unstable contraction occurs at 50 cc's, that would require medical treatment with pills and or Botox or neuromodulation, because that small volume diffuse overactivity will not respond to bladder training. The systometric capacity is a capacity that you measure during urodynamics. It is often lower than the functional capacity that the person measured at home. The ability to empty and the avoiding pattern is very important, and also cognitive ability. Can you train the person? If they don't understand you, they won't be able to do the behavioral training. All the instructions you give are not understood by the patient. That's why the instructions need to be at a level of about 4th grade to 8th grade education, very simple to understand in writing or with pictures, so that the person can follow your instruction. Because we as doctors have very little time to sit and explain to the patient. I use my nurses, my students to do this training better than I do. Painful disorders are often treated by physiotherapy and or muscle behavior training. This is very good for pelvic floor dysfunction. I see patients and also teaching them how to improve their capacity and appropriate use of Kegel exercise to abort a premature contraction. Dysfunctional voiding pattern is a way that you can make the diagnosis of either pelvic floor dysfunction in a person who does not have a neurological history. So just by a flow study, I can tell the person the flow is not normal, and we train them how not to strain and relax their pelvic floor. This is helpful in children. This is also helpful in adults who have a dysfunctional voiding pattern. So if you look at this algorithm, you have history, which is incontinence with physical activity, incontinence with mixed symptoms, urgency and frequency, and you have complex history. When you have complex history, such as associated with pain, hematuria, pelvic irradiation, these patients need to be referred to a specialist. Otherwise, just based on this history, you do a general exam, a diary, the quality of life, look at the pelvic exam, a urine analysis to rule out infection and bleeding, check a post-void residual, if necessary, with an ultrasound, and then proceed to treatment based on your presumptive diagnosis. The presumptive diagnosis is stress incontinence, mixed incontinence, or urge incontinence. In terms of any complex situation, once again, they get referred out. Most commonly, lifestyle intervention, bladder training is the first step in treatment, changing their behavior. Pelvic floor muscle training, and on the first drug in the urge incontinence or mixed incontinence is antimuscarinic or beta agonist. And on this side, the only approved drug outside the US is duloxetine. Not sure whether it's available in Haiti, but otherwise you need physical therapy and or devices, after which it becomes a specialized management, a person who treats them with more involved treatment. On the male side, we have a little more complexity because in the male, if he's over the age of 60 or so, we blame everything on the prostate, which is only part of the story. A small circle inside is prostatic enlargement, but a significant portion of men can have similar symptoms. So if a man of 60 years of age comes with frequency, urgency, and nocturia, you immediately remove his prostate. If a woman comes with frequency, urgency, and nocturia, you end up giving her a pill. And that's the learning we have to do, that men can have just as much bladder overactivity without the prostate involvement. So this is a big study done the epi-LUTs in terms of trying to understand over 71% of patients over the age of 40 reported lower urinary tract symptoms, and they can be voiding symptoms, which is my flow is slow or restricted, storage that I have to go frequently. Some can have post-micturition dribble, which is, as you can see, a big circle. The post-void dribble is a very common complaint in men, regardless of the age. And in terms of percentage, most commonly they have mixed symptoms in terms of both voiding and storage symptoms. A variety of symptom scores are available to help you assess. The AUA symptom score, or IPSS, which is the same, is helpful in scoring, but it's not qualitative. It doesn't give you the bother or the symptom. The score can be driven by one symptom alone, and that's why it's not specific. A variety of other questionnaires get more involved. There is associated erectile dysfunction, so SHIM or IIEF should be done at the same time. What's helpful is in patient screening. It's not a diagnostic tool. It's helped you from one visit to the other or to look at the treatment benefit, but IPSS doesn't make the diagnosis of a prostate obstruction. It is helpful as outcome measure and a research helpful, but it's quantitative. It doesn't tell you how many times or how often the person is going. And again, related to nocturia, it doesn't tell you how bothered and the volume of the urination. AUA symptom score is about the most commonly used symptom score It's used or converted into the 40 languages, and it's around the world that it is used. Its purpose also in clinical practice is very well validated. Let me go past this. There are other symptom scores available. Most recently, something called a visual prostatic symptom score. This is a picture depicting the flow rate and bother related to it on a Likert scale here. And by pointing to the stream in terms of where it falls, a patient who is not well educated to read the question and answer in a picture form can tell you how bothered it is. And if you ever treat or played the game of Angry Bird, you can use that to point where the picture is. The principal causes of male urinary tract infection can be bladder overactivity, just as in women during filling, outlet obstruction, which occurs in a percentage of patients, but detrusor underactivity, unfortunately, presents with a similar symptoms as overactivity. You can have frequency urgency as a presenting symptom. The problem is detrusor underactivity. You have nocturnal polyuria, particularly in patients who have sleep apnea, are obese, and can have the sleep disturbance and causing nocturia. So there are no typical symptoms of BPH or BPO. We need to define better its benign prostatic obstruction. Everybody has BPH after the age of 40. So you must try and define the symptoms. In general, if I'm bold to make this statement, nocturia is usually not a urological symptom. If it's selective nocturia, it's not due to a urological cause. You must find another reason for that urinary and not treat the person's prostate. It depends on how you evaluate. If you assess the flow rate and the bladder capacity, you can treat them better. OAB symptoms most commonly are related to bladder rather than obstruction. Trabeculations are not typical of obstruction per se, but it reflects bladder overactivity. The prostate size is only important depending on which treatment you're going to choose. Otherwise, it has a weak association with obstruction per se. So again, I would like to emphasize that the BPH is a histological diagnosis. Enlargement is what we talk about. Obstruction in a percentage of patients who have an enlargement, and outlet obstruction is a generic term that can be used for all outlet obstruction, whether it's prostate or urethral, including the prostatic obstruction. Guidelines are available. These have been recently updated. They're helpful in trying to define where you must intervene versus observe. This is a commonly used tool to be able to define your treatment. So if the medical therapy algorithm, if you have a patient and the IPSS is less than 7 and they have no or little bother, their prostate is small, PSA is low, there is no treatment required. If they have a large prostate or PSA is high, you can treat after diagnosis that the PSA is not due to malignancy, preventive therapy with 5-alpha reductase. Again, patient with no bother but an enlarged prostate. Beyond 40 grams is where finasteride is best helpful. If the patient has moderate to severe bother, the prostate is small, PSA is low, alpha blocker is the main treatment. If you have a moderate bother or no, it depends on how you treat the frequency and urgency. You can add an anticholinergic to the alpha blocker to improve symptoms and monitor their post-void residual. If they have moderate to severe bother and the size is large, then a combination of alpha blocker and 5-alpha reductase is helpful. The person who has moderate to severe bother and PSA is high, depending on the volume, then you end up using what else is to be used in the medical algorithm. What they have is a combination of 5-alpha reductase, combination therapy. You end up using 3 drugs in this situation, which is not very helpful. Beyond drugs, what you have is the minimal invasive option. Today, UroLift would be the most common. Resume is another one. Yeah. Okay. And the surgical therapies. That's how you would do it. Basically, you need to define voiding disorders in terms of overactive bladder or underactive bladder, increase or reduced resistance. Please excuse me for 1 minute. I'll be right back. I'm doing insertion on you. Yes. Sorry about that. So again, if I have to pick up the post-void dribbling, I talked about this earlier, is the fact that you have a person who does dysfunctional voiding, and what really happens is as you bear down, the urine gets trapped above the sphincter, and as the person walks away, the pelvic floor relaxes, and that small amount of urine will trickle out. We teach the patients not to push, and when they finish urinating, do a focused relaxation of the pelvic floor, and then to put their hand behind the scrotum and milk it forward to get rid of that drip so that they don't have the bother related to post-void dribbling. This is particularly a big problem in Muslim community where they have to sit down, wash their hands before they enter the mosque. And if they get up and they dribble urine, they have to do it all over again. So it's a big functional or social problem. The amount of urine loss is very, very small, but it's a very big bother. This can also happen in young women because of labial adhesions, or in obese females where the urine goes down into the vagina. As you can see in this picture, the person's urinating, but some of the urine is going into the vagina, and that causes an after dribble urination related to that. Urodynamic study is helpful to look at the flow pattern, which is very helpful screen. The residual urine volume. This is an important guideline principle, even for stress incontinence, to do a flow and a post-void residual. Filling cystometries to rule out detrusor overactivity. You have a voiding study. Fluoroscopically, it's helpful to know where the obstruction is or how much hypermobility is present. We measure leak point pressures in a person with stress incontinence, particularly in women. You have guidelines available on the AUA website. Please look at them in terms of assessing the need for diagnosis in terms of urodynamics. It's a very detailed assessment and looking at all the goals. This is an overactive bladder guideline. You also have refractory overactive bladder in terms of where you should be using sacral neuromodulation or Botox as a treatment. PTNS is the third line treatment for drug failure in overactive bladder. So this is, again, like I said, available on the guidelines when you can look at. There is also a guideline available for neurogenic bladder on the AUA University. You can certainly be helpful with understanding these guidelines. There are first line and second line treatment for interstitial cystitis, which is another guideline available in defining these treatment and treatment principles in terms of how you should address these patients. Finally, the stress incontinence guidelines tell you the use of sling and not synthetic sling perhaps are the most common ones used today. What is less recognized is the dysfunctional voiding. Most importantly, the role of pelvic floor. In our clinic, fully 25% of the patients we recognize have dysfunctional voiding that causes emptying problems. Letting go in life in general is good, especially during voiding. I think that's my last slide. I'm open to questions. Please, I'm ready to answer and help any other way I can clarify the situation.
Thank you very much for this topic. And we'll learn about and you have questions, guys?
You can text if you're shy to ask, otherwise everybody looks very serious. No breakfast, no coffee, no tea for anybody?
We have one question.
Yes. I hope
Dr. Desir, you're still muted. Maybe it might be easier to put the question in the chat for Dr. Badlani to read.
Or you can just bring your phone and I can't hear.
I can present for him.
Yes, sir.
Okay, the question is about incontinence. He told me, what do you think about treatment, like medical treatment of incontinence, and without the option of surgical treatment?
So medical treatment for overactive bladder is possible. First line treatment is behavioral training to moderate the fluid, timed voiding. The second line treatment is medication with anticholinergics, typically ditropan or any other medication of anticholinergic. A third line, or actually the extension, would be use of beta adrenergics, which is Myrbetriq and Vibegron now available. Beyond those medical treatments, we move to Botox as neuromodulation. For stress incontinence, there is no approved medical therapy available. However, we use off-label medication. Sudafed can increase outlet resistance, but it can raise the blood pressure. Imipramine has been used as a combination therapy, but duloxetine has been approved in the Europe, but not in the US. So among all the drugs available is duloxetine. Do you UCAP?
Not yet, they're just doing this.
Tend to go to the same. Okay, right. Okay, any other questions?
Question is about the nutria. We told that the nutria is not
A urological
problem of roots, right or no?
If I hear you correctly, is this question related to
nocturia? Nocturia is not a symptom for roots.
Nocturia is not urological. It's a metabolic problem. Metabolic problem is persons putting out too much urine. This is selective nocturia. If the nocturia is part of daytime frequency, then it is around the clock frequency. Whereas it's only nighttime getting up, daytime there is less or no frequency, then that has a medical reason, not a urological reason. Is that distinction is important. If the person has daytime frequency and nighttime frequency, that can be a bladder or an outlet problem. But if they have only nighttime frequency, large volume, and or small volume, then it's not urological. You can't have a problem from the bladder only in the day or only at night. It has to be around the clock. The bladder doesn't go to sleep. If the person has a lot of frequency during the day and they sleep the whole night, they don't have a urinary tract infection. They don't have an overactive bladder. Similarly, if they go up 4 times at night, but they hardly go during the day, then it's, again, not a bladder problem. So it's important to learn to discriminate, separate out the questions. If you ask the person, how many times do you go at night? The person will answer 4 times, and you assume they're getting up every 2 hours. But if I ask the same person, how many hours do you sleep without waking up? And they say 5, it doesn't make sense. How can you go 4 times and sleep 5 hours? Well, the sense is they go 4 times before they fall asleep. And then they sleep for 5 hours because they have sensation-driven frequency. Does that make sense?
Yes, yes. It just my my point is, if Nigeria is like isolate, and that means it's not a biological problem.
Yes.
Now, is one for Nigeria plus other like frequency and other disorder. That means we can talk about urologic problem.
Yes, daytime and nighttime, urological. Only nighttime, not urological. Okay.
Thank you. That's what I would like to fix.
Yeah, 1 second, I'll be right back. Sitting right here, it's like you have to be so anal about the fact that I have to show my face inside the door, not outside. Yeah. So, go ahead. Agree. Okay, any other questions?
And the question is, when is it that asked about like sometimes the patient say, I drink something before I go to sleep, and I have to wake up like 5 or 6 times. But if I don't drink anything, I can wake up about 2 or 3 times. He told me, what do you think about that? Can we consider that about like a problem or no?
So again, if the problem is associated frequency in the day, that person has reduced urine bladder capacity, and by increasing the volume at night, they're urinating more often. So you have to look at the combination of drinking in the last 2 hours, plus the mobilization of the fluid that occurs from the legs as they lift their legs up at night. All that fluid in the legs is coming back. So the first 2-3 hours of the sleep, they have the maximum urinary output. So if they don't drink, obviously they'll have less volume. So the general instructions for a person with nocturia, even with children with nocturnal enuresis, is not to drink the last 2 hours before going to bed, and elevate the legs in the evening hours to reduce peripheral pooling. By that, you're reducing the volume. Nocturia can be best assessed by measuring the urine output from the time they go to sleep to first thing in the morning. And that defines for you what the problem is. If the person's urinating a lot at night, then you have to look at why they're urinating such a large volume. Is it intake? Is it use of diuretic inappropriately? Is it peripheral pooling? Or they have sleep apnea or diabetes insipidus or some other reasons why they're putting out such high volume at night. But again, that requires medical treatment. But if they have a large post-void residual and they're urinating frequently, again, that's a urological problem.
I have a question. I have a case, a patient that we had like a large prostate. Before, when I made the diagnosis, the patient had like adenosis, secondary with the BPO. And not BPO, like BPD. And when I did the prostatectomy for the patient, after that, it can be well because the bladder is like very like
It's a contractile. It doesn't, yes,
like a bad bladder.
yes.
And what do you recommend for this patient?
So when a person comes with bilateral hydronephrosis and retention, that typically is a person who's had long-standing retention. Their bladder, because of stretching, has lost its contractility. You can try prostatectomy, but it's much simpler to put in a suprapubic tube only and give them trial of voiding and drainage till such time that the hydronephrosis has disappeared and the bladder contractility has returned. I measure that by urodynamics before I would operate on the prostate. Or the person can do self-cath. It is important to check that the hydronephrosis has disappeared once you've drained the bladder, because if it doesn't, then you have an obstruction at the uretrovesical junction from a thickened bladder. That requires more treatment, either stenting or nephrostomy, and because the drainage of the bladder alone will not suffice. Okay?
Thank you.
I have a review article on this, bladder effect causing hydronephrosis. That's in the Gold Journal, which defines the algorithm for a person who comes with a hydronephrosis and a full bladder.
Thank you. Thank you. No more question? No more question now. Thank you very much, Dr. Gopal Badlani.
My pleasure. Have a wonderful day. Thank you again.
Thank you, Dr. Badlani, and thank you, Dr. Desir, for organizing.
Bye-bye.
Thank you, Ashley. Bye-bye.